Yep. So hi everyone. Thank you so much for joining this seminar with us today with Dr. Jithoo on the topic of traumatic brain injury. So during the presentation, the attendees will be muted to avoid any random noises that might distract the presenter. If you have any questions, please pop them in the chat box below and we will attend to them at the end during our Q&A session. So today we have Dr. Jithoo, who is a neurosurgeon. He has completed his medical degree with Dean's Commendation in South Africa in 1992, and then completed neurosurgery training in Durban and Melbourne. He holds fellowships of the College of Surgeons of South Africa and Royal Australasian College of Surgeons by examination. So over to you, Dr. Jithoo.
Thanks very much. So thank you, Sophia, and good afternoon to everyone who's logged on today. I might just share my desktop. All right. Can everybody see my screen?
Yep.
Yep. Okay. So I'll say good afternoon again. Thank you for this opportunity to speak with our legal colleagues on traumatic brain injury. This is a condition that sits at the intersection of medicine and law and society. As a neurosurgeon, I often see firsthand the devastating impact of brain injuries on the patients, but not only that, also on their families and the communities. What often happens is there is a discussion regarding the outcome of these patients, and these cases are particularly challenging. They are very medically complex. The diagnosis is often clinical rather than radiological. Prognosis is variable and dynamic, and I'll talk more about this later on. There are subtle cognitive and behavioral changes that can be as disabling as neurological deficits. So I'll try and provide a shared understanding of the medical framework and what would the neurosurgeon can do to make a fair and consistent and well-informed legal decision. So this is just a bit of background about myself. We've been through my basic training. I do have some background in the military as well, but most recently, I have statutory appointments as a federal advisor to the Health Minister, Mark Butler, for traumatic brain injury. I'm a member of the Veterans Review Board, dealing with mainly the Veterans Entitlement Act, and a member of the Victorian WorkCover panel. In that, we deal with the WorkCover Act and also questions that come from the courts under the Wrongs Act. Last year, I was an invited member for the Brain Trauma Foundation guidelines meeting in Washington regarding guidelines for traumatic brain injury. And I'm currently involved with the recommendation 61 of the Royal Commission as part of the Veterans Administration for advisory panel. So on to traumatic brain injury. I think for lawyers, these cases are complex. There are issues of liability, compensation, and disability assessment. I draw your attention to the clinical guidelines. This plays a crucial role in standardization of management and evaluation of traumatic brain injury. And this gives us something that is reproducible across medical and legal assessments. I think Sophia will make my slides available to everyone later on. Traumatic brain injury occurs when an external force causes brain dysfunction. So it's actually a spectrum, starting with concussion, where there is no structural damage, and on the other side is focal brain injury causing coma, where there is a fracture of the skull, damage to the structure of the brain, and so on. So an external force causing brain dysfunction. Mild traumatic brain injury is often referred to as a concussion, and this is very topical, especially with the AFL and minor traumatic blast injury amongst veterans. It may not involve loss of consciousness, and when a scan is performed, the scan would often look normal. So there is often microscopic damage. Moderate traumatic brain injury is characterized by longer periods of consciousness with or without neurological impairment, and severe traumatic brain injury is usually due to significant brain damage. So common causes would be falls, which is very common, motor vehicle accidents, assaults, and sports injuries. These are the commonest general causes of traumatic brain injury. How does one evaluate medically a patient with traumatic brain injury? As a medical practitioner, I would assess the consciousness level. And here we use the Glasgow Coma scale. This is a scale and a tool that is used for evaluation of level of consciousness, and it's out of 15. The highest is 15 and the lowest is 3, using eyes, motor, and verbal responses. CT scan and MRI scan are extremely useful. Nowadays, large trauma departments, I work at the Alfred Hospital in Melbourne, which is the Victorian State Trauma Centre. These departments have a CT scanner within the emergency department, and it's essential for identifying structural damage to the brain. A physical and neurological examination is invaluable in patients who can cooperate with this. When one's patient is in a coma, the examination is slightly different, and I'll go into that a little later on. Usually, further down the track, evaluating cognitive deficits. So neuropsychological testing is often used to assess cognitive and functional impairment. And this is looks into features of executive dysfunction, such as memory, insight, judgment, problem-solving abilities, mathematical calculation. So, you know, why are we here today? Why is it important to hear from a neurosurgeon? I think a precise medical diagnosis is crucial in a legal context. This ensures that the severity of the condition is accurately represented. The diagnosis and quantum of impairment has an impact on the compensation claim. And your plaintiff or your client would have the rightful entitlement. The precise diagnosis either supports or challenges the causation or liability argument in determining responsibility in a dispute. And the medical diagnosis usually provides objective evidence for court proceedings. We often see this on the Victorian Medical Panel under the Wrongs Act, where a question is received from a judge, and I particularly find those reports very straightforward, and they're often very short, and the reply would be in an affirmative or negative, because the judge or the legal professional is usually across all the salient points of the case. There are risks of inaccurate diagnosis. So an incomplete diagnosis or a rushed diagnosis can lead to a poor outcome for the client. Okay. Impairment rating scales used in Victoria are the American Medical Association 4th edition, and in other jurisdictions 5th and 6th edition. And I would take it that most people are conversant with the application. They take into account neurological, cognitive, and psychological factors and gives one a thorough assessment. So chapter 4 is the nervous system. Going through the actual guide and the relevant chapters would be too much for a short talk like this. My intention is not to turn you into an impairment assessor, but to give you some background. In some countries, the practice of neurology and psychiatry is actually combined. I've done some training in Germany and in France, in Montpellier. And when I'd gone across, I was surprised to see that psychiatrists and neurologists were often in the same department and were regarded as one profession. This doesn't occur in the English medical system that we follow in Australia. So my point of mentioning that is these structural problems in the brain with neurological outcomes can often have psychological factors that come into play, and often a medical assessment or neurological assessment and a psychiatric assessment may be required to pick up subtle nuances in impairment. So applying the impairment scales for traumatic brain injury would be straightforward in that comprehensive clinical evaluation is required, starting with a history and a thorough examination, going through the relevant records, identifying neurological deficits for pinpointing the areas affected by the traumatic brain injury. So this is easier said than done, as neurology and understanding of neurology is generally poorly understood by general practitioners and by practitioners other than neurologists and neurosurgeons. The brain itself is hidden, it's occult, and it displays its functioning through the workings of the neurological system. Each subdivision of the brain is responsible for something completely separate. It's the most complex organ in the human body, or indeed in the known universe. Very different to the functioning of the lung or the liver or the gut or the heart. The AMA guides were then applied to assess the percentages, and findings are documented with supporting evidence, and this is eventually integrated into a legal report. So that's pretty straightforward. So what are the challenges of the AMA scales? There can be variability in evaluator interpretation. So often a panel is required, and with the Victorian medical panel, there's usually 3 practitioners that sit. It's difficult to capture cognitive and emotional impairments, and this is where a psychiatric evaluation is very important. The AMA scales are found personally to be most valid where the condition has stabilized. They have a limited sensitivity to an evolving symptoms or subtle symptoms, and this may confuse or hinder tracking of changes. And depending on this, the scales used, there's a possibility for under or overestimation of these ratings. So it's essential that the limitations of the scales be recognized, and this would help in their interpretation. Similar to the AMA scales, neurosurgeons have the Brain Trauma Foundation guidelines, and I'll allude to this later on. The purpose is evidence-based guidelines, which are dynamic, and they're revised every 4 or 5 years. There's a focus on standardized care, so the care is not made up on the spot, and these are internationally recognized guidelines. They're informing both medical practice and legal standards, and the design is to improve patient outcomes. And my slides at the end deal with the brain trauma guidelines in more detail. Some of the key assessments and recommendations from the Brain Trauma Foundation are early assessment of traumatic brain injury severity using the Glasgow Coma Scale, intracranial pressure monitoring using a wire inserted into the brain via a burr hole, certain protocols regarding intervention where the patients are grouped into tiers, and rehabilitation and long-term care. This is extremely important in the spectrum of traumatic brain injury care. the Alfred Hospital, where I do most of my work, has a separate hospital called Caulfield Hospital, where the acquired brain injury unit resides, and rehabilitation physicians, occupational therapists, physios, psychiatrists, and psychologists will attend to the patient for long-term care. And then obviously, clear documentation and thorough documentation goes without saying. So there's a lot of integration required between the medical and legal frameworks to ensure that one's client gets fair compensation and care. It goes without saying that detailed clinical notes are extremely important, and they're much better than memory. Sometimes clinical notes can be wrong, but the clinical notes are there for the patient's care and for review by other physicians who are involved in the management. The use of standardized impairment scales and guidelines is always recommended, and this always would support the legal outcome. Certain ethical considerations in medical legal cases. I think it's important to avoid bias in impairment evaluations, the so-called guns for hire. These are ethical dilemmas, and this often arises when balancing patient confidentiality with the need for legal disclosure, and careful navigation here is required. Informed consent for assessments. Often when I see patients for independent medical evaluations, I often explain that I'm not a treating doctor, and many patients are often surprised by this. And then despite me telling them this, at the end of the consultation, the majority of patients will ask me what they should do and what treatment is best for them. So this may be a human effect thing. Despite telling patients you're not there to provide advice, they still ask you for advice. And here, this is where conflicts of interest may come in, and obtaining informed consent for the relevant examinations and assessments. So in terms of some future directions in medical legal TBI management, there are certain biomarkers in the CSF that are coming up that can make early diagnosis, especially in concussion. So this can be assessed in the blood or the CSF. Still experimental. Refining impairment scales is always something for improvement. And what we're doing now, interdisciplinary training for professionals. Telemedicine and digital documentation are really things that are on the horizon. Artificial intelligence, AI scribes. Currently, the use of artificial intelligence is frowned upon when answering medical legal questions, but many doctors are using artificial intelligence scribes for transcribing general medical consultations. This tends to make things much more simpler. However, the artificial intelligence does need to be checked, as it is not always reliable. Some of the takeaways to consider would be having standardized AMA impairment scales, using evidence-based clinical protocols, doctors and lawyers collaborating together, ensuring the best ethical outcome for our patients. I'll go on to some common mild TBI symptoms. So these can, as you can see, this is why traumatic brain injury is difficult. Nausea and vomiting, dizziness or balance issues, headaches, confusion, sleeping more or less, and anxiety. This could be almost any kind of stress symptom. More severe symptoms would be losing consciousness, having hearing or vision issues, and these can be quantified in the AMA guides. Aggressive behavior, changes in sensory perception, or trouble in communicating. And patients who have this, would often get fired from their place of work for being disruptive, as employers may not understand. So in definitions of traumatic brain injury, we spoke about the dysfunction caused by external mechanical force. There is a primary and secondary injury. So the primary injury is caused by the actual injury itself, that is, being in a car crash, having your head hit the steering wheel, or being ejected into a tree. And that is often irreversible. The primary brain injury usually determines the prognosis. Secondary injuries are subsequent swelling, ischemia, or low blood flow to the brain causing stroke. This occurs in the period after the immediate accident. So at the roadside, if it's a motor accident, being transported to hospital, and during the treatment process. The traumatic brain injury is extremely common. It has long-term consequences and a very high economic impact to society via the taxpayer. One example is the use of mobility, the two-wheeled electric scooters, which have proliferated, and this has caused lots of examples of traumatic brain injury presentation to casualty emergency departments. So I'd like to come back to the international guidelines, the Brain Trauma Foundation guidelines, and having importance of a standard of care in liabilities. This serves as a benchmark for evaluating the care of the patients and other professionals involved with the management. I'll go back to the clinical assessment methods, the Glasgow Coma Scale, and imaging techniques, such as MRI scans, which are very good in the long term, and CT scans in the acute phase. Long-term rehabilitation is often underutilized. Where I work up in the Northern Territory at the Royal Darwin Hospital, there are no long-term rehabilitation facilities for neurological injuries. These patients are often sent a good 3,000 kilometers away to the Royal Adelaide Hospital or Flinders Medical Centre in South Australia. So you can see you don't have to go outside Australia to see deficits or problems in the delivery of care. With traumatic brain injury, there are patient consent challenges. Most of my acute patients that I operate on are operated on the chief medical officer's consent, as we often cannot contact relatives or next of kin when a patient comes in at 1 a.m. Some patients do not have any identification on them. They're brought in by the police. And when we see a large bleed in the brain, the duty of care is that we will then proceed to provide the optimum surgical care for the patient. So this is a complex decision making, and often the next day, a surrogate decision maker may attend the ICU, and a discussion will be held at that stage. Sometimes the spouse or the children of the patient may come forward with an advance directives, and an advance directives are extremely important in end-of-life care. So there's a careful balance between beneficence and autonomy, and increasingly surrogate decision-making, medical power of attorney is often sought, and failing that, the Office of the Public Advocate for our patients, where a guardian is then appointed to make these decisions on behalf of the patient. I currently have 2 patients who are under guardianship of the Office of the Public Advocate in Victoria. And this leads on to dispute over informed consent, and then often to medical negligence claims. Here, one often goes back to causation and liability, and what is the actual standard of care. Medical records are extremely important as evidence in documenting the injury, treatment, and outcomes. Nowadays, many public hospitals are using automated recordings in the operating theatre, similar to a black box, So the anesthetic department, for example, uses automated recordings of pulse, blood pressure, respiration, oxygen concentration through the anesthetic machine. So it's very much like an aviation black box recording all the time. So this gives a very factual basis for understanding what happened if a large blood vessel started bleeding, the blood pressure went down, the patient didn't recover, there was a cardiac arrest. And I think we're probably getting to the stage now where artificial intelligence will have continuous recording during consultations and give verbatim transcripts. This is often at the consent of the patient. Having witness statements and reports is useful because this can provide a context and corroborate the events leading to the injury, such as a motor vehicle accident or a fall from a ladder. The role of expert testimony, this is where someone like myself or an experienced neurologist or rehabilitation specialist is useful to help interpret what is often disparate medical findings in a dynamic situation that is often evolving into the future and explain the implications of the injury to the court. It goes without saying the chain of custody and maintenance of this chain is vital, and forensic imaging and testing is often the final word for substantiating claims once one has the coroner's report. The role of the expert witness in influencing verdicts is often a very critical aspect of traumatic brain injury related cases, and the testimony can significantly sway the outcome of the trial. The expert witness should be informed by standards of care and informed consent. And often there are lessons learned from precedent. Your expert witness qualifications should have at least 10 years experience as a specialist and have some type of postgraduate training, usually fellowship level specialist knowledge in neurology, psychiatry, forensics, or neurosurgery. This provides the knowledge base, a very strong knowledge base to influence the outcome. I think the confidentiality and secure storage of records. Nowadays, with electronic medical records, this is quite straightforward in that medical records are stored. There are still large public hospitals that have paper records, and this can be difficult where pages go missing. Often, lessons learned can implement safety protocols. So if a particular device, such as, say, a two-wheel scooter, is causing a spike in the incidence of traumatic brain injury, public health epidemiologists can look at this to try and ensure a safer environment through public education campaigns and healthcare provider trainings. Each institution has a unique policy to minimize its own liability towards medical legal risk. Traumatic brain injury is very complex, and I would say that ongoing education and risk management is extremely vital. At this point, I'd like to talk specifically about traumatic brain injury and the subdivisions, and I don't make any apologies for repetition. I think that's important. So clinical priorities when a patient arrives is your clinical ABCDs: airway, breathing, circulation, having an urgent CT scan or an MRI scan, and a rapid decision as to go to surgery or conservative management. Rehabilitation is long-term and resource-intensive. The mechanism of injury is extremely important, as this goes to the primary brain injury, sort of high energy transfer like a motorcycle accident versus low energy fall from your own height. contemporaneous and factual notes, which avoid speculation, as the documentation is often scrutinized. With the patient or client, it is important to be aware that traumatic brain injury, especially to the frontal lobes, can impair decision-making capacity, and these individuals can often become impulsive. Assessing and documenting the cognitive status is important. There are certain standardized tools, such as the Glasgow Coma Scale, the Montreal Cognitive Assessment, or the MOCA, and involving substitute decision makers such as spouses, medical power of attorney, early on is extremely important. Having the correct interpreters present for the individual is just as important as having, say, failure to assess their capacity, which would bring on some vulnerability from a legal point of view. Common pitfalls are missed or delayed diagnoses of an expanding hematoma, failure to monitor or document a neurological deterioration, inadequate counseling on prognosis or risks, and incomplete discharge instructions or follow-up planning. The nature of traumatic brain injury is such that earlier on I said that these individuals may become impulsive. So more than one patient of mine has taken his own discharge from the hospital and walked out without any discharge instructions or post follow-up medication. In this case, the hospital usually activates the Victoria Police, who try to track down the individual and bring them back to the hospital if they can. I'd make the diagnosis between treating clinicians versus independent experts and the duties which are impartiality and evidence-based opinions. It's said that the better you understand something, the simpler you can explain it. So this is a skill that is not that common. So structured, well-reasoned reports are extremely useful. Often in workers' compensation, transport accident commissions, or WorkCover insurance claims, there's a dispute as to causation, extent of disability, and future care costs. So here, the importance of psychiatric or neuropsychological assessment cannot be underestimated. Having a missed bleed, like an epidural hematoma, would lead to a catastrophic outcome, resulting in usually resulting in successful litigation. There are persistent post-concussion syndromes, such as in the AFL footballers. This is currently a challenge for compensation in assessing these patients. Patients with severe traumatic brain injury will often have lifelong high-value claims, because that claim is meant to last them for the rest of their life, and specialist care as well. So best practice recommendations would be to follow trauma and neurosurgical guidelines, ensure that meticulous and objective documentation is prepared. Nowadays, with black box type recordings, this makes things much easier to work out what has gone on. Early communication with patients, their families or medical power of attorneys, and their legal representatives is vital. And having an interdisciplinary approach between the medical and legal professions can only improve outcome for the client or the plaintiff and reduce disputes. Good care protects both the patients and the medical and legal clinicians, and it's essential to have good collaboration between the two. Some cases that I picked up were Queensland versus Mason, paramedic traumatic brain injury case, where the individual was not given adrenaline at the roadside, and the court held that the responsible body of clinical judgment was lawful. So that's an important case to look at. Albrighton versus the RPA hospital. This was related to the Bolam standard of care regarding a patient with scoliosis who was put into traction and became paraplegic. Again, a very complex case. Discussion of this said that the duty of care does extend to the consulted specialist, and customary practice is not conclusive. each of these cases can be the subject of an entire hour discussion. The famous Rogers versus Whitaker, the duty to disclose material risks. So in traumatic brain injury, the failure to warn of risks or poor prognosis may lead to ongoing liability. This is not as relevant for patients that come in coma, and I think it's just as important to inform the medical power of attorney. This is an interesting case, Haji Pavlo versus Allianz from January 2025. The dispute as to whether the accident and the fall that the plaintiff had caused a traumatic injury, or whether there was only psychological injury present that was pre-existing. So I think this is quite an interesting case to review. So here, objective evidence, that is imaging, MRI imaging, and neuropsychologist evaluation and psychiatrist evaluation was crucial to support the causation and as to whether traumatic brain injury had actually caused the injury or not. So this is a sort of a standout case I'd refer you to. And here, I hadn't gone into this one as much, but the court accepted PTSD as a brain-based injury, and this expands the medical legal scope of brain injury complaints, especially regarding the veterans practice and the Veterans Administration practice. The AFL class action, which is ongoing, the link to chronic traumatic encephalopathy, CTE. This was publicized in the National Football League in the United States with the other term was dementia pugilistica. The classic example here was Muhammad Ali, who developed Parkinson's disease after many blows to the head. So this is sort of a watch this space where cumulative concussion litigation will evolve, and there's a duty of care in sports medicine. Some take-home points is that accurate objective documentation is the strongest defense. Risk disclosure and capacity assessment must be explicit. Causation is the thing that's scrutinized, and here objective evidence from imaging and neuropsychology, psychiatric, neurosurgeon, neurologist report is critical. And then again, I'll come back to collaboration, ensuring fair outcomes. This is the Brain Trauma Foundation guidelines. I'm not going to go through the entire guidelines, and I've included these slides purely as some background reading for those of you who are keen, just to show where the intracranial pressure monitor sits in the brain itself, placed through a burr hole, and we get a particular readout for intracranial pressure and cerebral perfusion. I think that's really all that I wanted to say. Not sure about time. I think we might open the floor for discussion.
Yeah. So thank you so much for that, Dr. Jithoo. We do have a few questions that came through in the chat box, so I'll go over it one by one. So the first one is from Leah. I'm keen to know if there are any new psychosocial trends resulting in increase or decrease of TBI in the past 10 or 15 years. Example like substance use, domestic violence, workplace issues, MVAs.
Okay, thank you. I think that's a very sort of deep question. So the answer would be, the short answer would be yes. For example, in my practice up in the Northern Territory, I see the incidence of domestic violence in vulnerable communities such as Indigenous communities, and then there's also gender-based violence that is now coming to the fore as well, which is linked to substance use such as alcoholism, bringing in new devices for transport. I alluded to the two-wheel electric scooters, which one doesn't need to wear a helmet for, especially here in Melbourne. This has a significant effect on traumatic brain injury. So my answer would be yes. It would vary according to the different areas of practice. But I think traumatic brain injury is very much evolving according to the different habits of society.
Thank you, Dr. Jithoo. Can you stop sharing your screen so that?
Oh, yes.
Yeah.
How can I do that?
And
can I?
Oh, you can just stop sharing. Like you have to open Zoom again and then just stop. Yeah. So that when you talk, it will show up for the full screen.
Okay.
Can you just go out? Actually, I'll see if I can.
Maybe you can.
Look.
Okay. Stop sharing.
Okay.
Here we go.
Yeah.
How's that?
Okay. So, great. Now we're gonna move on to the next question from Siobhan. How is artificial intelligence advancing the diagnosis and treatment of TBI? Please share any applications within the Australian context.
Okay, thank you. I think that's a really sort of cutting edge question. I'm actually involved with some artificial injury research with Deakin University, with the AI group. There are problems associated with artificial intelligence, such as confabulation. So when you ask an artificial intelligence such as ChatGPT, Perplexity, Google Gemini, whatever you talk, whatever, insert whichever one, any large language model, the artificial intelligence cannot say that it doesn't know a topic. So if you ask me, what about, what happens to people in South America who get a particular disease? I'll say, look, I don't know. I don't practice in that environment. The artificial intelligence will go back and look at archaic articles from the 1950s and incorporate that into its answer. And if you don't have any background knowledge, you may then take that answer as the gospel truth. So we call that confabulation in artificial intelligence. That's the first thing. The second thing is artificial intelligence. When you ask it the same question on a different day, it gives you a different answer. So we call that hallucination. So the artificial intelligence hallucinates. So you ask, someone's had a concussion, should they return to playing footy after a week? And it might say yes today. And you give it the same thing, same problem tomorrow, it will say no. So in that way, confabulation, hallucination is these are some problems that we have identified in the usage of artificial intelligence. Thirdly, artificial intelligence often gets exhausted when you present it with a very long, complex topic, such as an independent medical examination review. It will often summarize it incorrectly. It seems to get exhausted or tired in terms of very, very long reports. So at the moment, I think artificial intelligence, it may be good for performing things where there is precedent, where it looks backwards in time to previous records, where you give it a good prompt, when you download previous transcripts into it, and then ask it to revise a document, it seems to be good at that. Asking it to provide a medical diagnosis and a prognosis for something that is dynamic and looking into the future, as opposed to looking into the past from that point in time, that's still something that is evolving and unpredictable. So I would say, feel free to experiment with the AI apps, but I probably wouldn't be asking it medical problems just yet.
Yeah, thank you. So we'll move on to the next questions. I think there are around 4 more. So another one is from Kelly. How post-injury are you able to determine the psychological impacts of TBIs? Or do you focus more on the cognition in those initial stages?
Yeah, thank you. I think that's a very important question. So very early on, if we take a patient with severe TBI, they're often on a ventilator in the ICU, and they can't really speak or be assessed. In that case, we assess them through their pupils. We place a wire in their brain to assess the pressure. Once they recover, it's like a diver ascending to the surface. Their consciousness slowly improves week by week. And often when we see the patients at 6 weeks or 3 months in the outpatients, they can often communicate with you, but they often have no memory. There's a total retrograde amnesia that is present due to the traumatic brain injury. So a thorough neuropsychological assessment would be useful, but this is often done at the 3-month mark or the 6-month mark. Doing it prior to that would be counterproductive unless you just want it as a baseline, because the condition has not stabilized yet. So if there is mild traumatic brain injury, such as a concussion, this is where neuropsychological assessment is extremely useful. And that may be undertaken in a shorter time frame, like say within a week or 2 weeks, and then repeated to look for improvements. So there's a spectrum of cognitive assessment. I'm not sure if that answers your question.
Yep. Kelly, if you have any more questions, just pop them in the chat box there. So we'll move on to another question. Do you have any broad views on the long-term prognosis for TBI? Is it always progressive, or is there any link TBI progressing to Alzheimer's disease, for example?
Okay, so to do the second part first. So yes, there's a clear link between traumatic brain injury and early onset dementia. Certain vulnerable populations, like in the Australian context, this would be, say, gender-based violence, usually perpetrated on females. There is a link between early onset dementia in older women and traumatic brain injury due to domestic violence. I would say that there's definitely a link between brain atrophy due to chronic trauma. It is well known that chronic alcoholics who fall over, they often get shrinking of the brain due to alcohol consumption and subsequent bleeding into the membranes that surround the brain, causing mass effect and neurological impairment. Can you repeat the first part of the question again for me, please, Sophia?
Yep.
What is the first
You want
part?
to repeat the question?
Yeah,
do you have any broad views on the long-term prognosis for TBI? Is it always progressive?
So the long-term prognosis is not always progressive. There is something called neuroplasticity. So neuroplasticity is the ability of the brain to recover. So it was thought that the brain could not recover at all, and certainly in adults and older patients, the brain has much less reserve and does not recover as well. In young children, there's something called neuroplasticity, where other parts of the brain can then take over the functioning that has been impaired or destroyed by the trauma. The actual prognosis of traumatic brain injury is determined by the primary brain injury. So if one fell from one's own height, you'd have a better prognosis than if you were riding your motorcycle at 100 kilometers an hour and you crashed into a pylon or a bridge on the side of the road. The energy transfer is much more, and the brain tissue reacts in a different way physiologically. So long-term prognosis is not always fixed. It usually can stabilize, and after a certain period of time, and usually I would say that's usually around 2 years. Many times, when we assess people for long-term prognosis, patients are often found to have untreated problems, such as chronic subdural bleeds, post-traumatic hydrocephalus, where the water is in the brain is blocked, and that causes hydrocephalus. And often when that is treated, the patients often make a dramatic recovery, neurological recovery. So the answer is that prognosis can be variable. it may improve with neuroplasticity, but that's usually assessed at the 2-year mark.
Yep. Thank you so much for that. Now we'll move on to another question. So this is, yep. So from Maria, if the brain injury impairs cognitive or behavioral control, leading to chronic overeating, physical inactivity, loss of motivation, or poor self-care, this can significantly increase the risk of secondary medical conditions such as type 2 diabetes, obesity, cardiovascular disease, gastrointestinal problems, and metabolic syndrome or musculoskeletal issues. The difficulties I face is establishing that causal connection early, as cases are usually settled in within 3 to 6 years, and these secondary conditions often take years to develop. What advice do you have to establish the chain of medical causation from brain injury to secondary illnesses?
Okay, so that's a great question. The deeper structures in the brain, such as the white matter, like the hypothalamus, are involved with control of our metabolic responses. So there are neurological syndromes seen in children who are born with a problem in the hypothalamus called Prader-Willi syndrome. And Prader-Willi syndrome involves compulsive eating and loss of the satiety response. When individuals have traumatic brain injury, there is loss of the frontal lobe function, which has an inhibitory function on the deeper brain structures. So the frontal lobe is a bit like the rider of a horse, and the horse is the deeper brain structures, such as the hypothalamus, that are responsible for our involuntary functions, such as eating, sleeping, hunger, satiety, libido. So the frontal lobe keeps a check on these impulses. So when patients have frontal lobe damage, the rider of the horse is then lost, and the horse is then running free. I actually have a patient who has this problem after a suicide attempt where she drove a car into a tree, and she has no filter. So when you meet her, she will tell you that you look like the ugliest person she has ever seen. And so on. So she doesn't endear herself to the medical staff or the administration people, but an understanding of the loss of frontal lobe inhibition is important. So you're quite right. These conditions can take a while to develop. Usually you would see them at least by 2 years, and a psychiatrist's evaluation is useful, looking at involuntary autonomic disorders. So I would say if you wanted to look at the a full assessment of your client, having a psychiatrist evaluation at 2 years, looking at chronic features of traumatic brain injury. Often this goes hand in hand with depression and other psychiatric problems as well, leading to metabolic issues.
Yep. Thank you. So 2 more questions. The first one here is from Jacob, who said, I have a number of clients who have suffered a head knock, who are initially diagnosed with a TBI, but upon medical legal assessments are told their symptoms, poor memory, dizziness, relate to a psychological condition. However, I rarely see clients who have a psychological injury who have not had a head knock with these types of symptoms. Is there a link between head knocks and developing these types of psychological symptoms?
Okay, so I think the brain itself is the link between the mind and the neurological system. So having a head knock and then having symptoms which we might term a dysexecutive syndrome. So dysexecutive syndrome would be difficulty in calculation, having problems with your memory, word-finding difficulties, being unable to recognize friends and family members. This would be termed a neurological syndrome called dysexecutive syndrome. And certainly, this can be related to traumatic brain injury. Again, having appropriate imaging, such as MRI scan, combined with a neuropsychological evaluation, would be very useful. Many people have head knocks, and the majority of people do not go on to develop a psychological or dysexecutive syndrome. And that's just from the volume of patients that we see in our hospital. They might have symptoms, but they're often able to continue, and the brain often adapts. There's a certain amount of neural adaptation that occurs to enable them to continue with their life. And it's usually the minority, the tip of the iceberg, that will present with ongoing symptoms. So the short answer is yes, there is a link between knocks on the head and traumatic brain injury. We might term that the post-concussion syndrome. And I think having a post-concussion syndrome, this is often seen in sports injuries. And this is probably the topic of maybe another talk, given the complexity of post-concussion syndrome. But there's definitely a nexus between having a knock on the head and having ongoing concussion symptoms.
Yep, thank you. And to our last question, how long does it normally take for a mild concussion to be stationary? Is there any expected time frame?
So when one uses the term mild, you would expect recovery within 24 hours. There should be no loss of consciousness. There should not be any retrograde amnesia. And there should not be any ongoing headaches or dizziness, difficulty in concentrating, neck stiffness. So if one has those symptoms, then you would sort of move into the mild concussion or severe concussion area. The important thing with concussion is that there is a metabolic interruption in the brain, not a structural disruption. So when you perform a CT scan or an MRI scan, it looks normal. And it looks normal because there's a disruption at a cellular level. The sodium and potassium ions are changed across the membranes in the brain, and there's this temporary or transient cessation of impulses, and then things start again. So there can often be profound neuropsychological issues further down the track. So I hope that answers the question.
Yep. So that's all for the questions today. So I think we can close the Q&A session off now. And thank you so much, Dr. Jithoo, for presenting with Meg. Yeah, so everyone said thank you. A wonderful presentation. Very much looking forward to the slides and watching the recording again. So yeah, this will be, I will upload the recording on our YouTube channel, and I'll send out like the presentation slides to the attendees.
Yeah, no, thank you very much for having me and for all the great questions. I really enjoy the questions because that's the actual, collaboration between the medical and legal professions. That's the crux of the collaboration. That's why we're here. Hope people haven't missed their lunch and they're hopefully they're munching on their sandwiches at their desk. The slides themselves, I purposely built in some repetition for the important points, and I don't make any excuses for that. The slides at the end on the Brain Trauma Foundation, I don't want to make neurosurgeons out of you, but they're there as a resource. And please feel free to go through the slides as a resource. And, I can always be contacted through Sophia and the MAG practice as well.
Yep. Thank you, Dr. Jithoo. Thank you, everyone.
Thank you very much.
Evening. Thank you. Bye bye.
Bye. Bye-bye.